Hello, welcome to this presentation. I'm Charlotte, I'm one of the UKFPO Leadership Fellows, and today I would like to share the new Foundation Programme curriculum with you. The UKFPO have been working with various academic and regulatory bodies to develop a new curriculum, and this curriculum has responded to trainee feedback and also acknowledges developments in medicine and social changes too. It will be implemented August 2021. So new F1s will start on this curriculum and F2s will transition onto the new curriculum from the old one in August. So without further ado, next slide please. In this next hour or so, this talk will give an overview of the new curriculum and it's split into three parts. Firstly, I'll talk about the aims of the Foundation Programme, so the outcomes. And these are split into higher level outcomes. Then I will talk about the approach, which is how the Foundation doctors learn during the Foundation programme. And finally, the assessment. So what evidence you need to show achievement of the standard required for progression in the Foundation programme. So a quick note first on the role of the UKFPO. The UKFPO manages the national application process and it facilitates the operation and continuing development of the Foundation programme. The organisation has worked with multiple educational and regulatory bodies to develop this curriculum. So briefly touching upon how the Foundation programme delivery is organised, the UKFPO provides national guidance on the delivery of the programme. You then have your 4 devolved nations, England, Northern Ireland, Scotland and Wales. And these are further organised into Foundation schools who implement and oversee the delivery of the Foundation programme in their region. Looking locally, you'll have your local education provider, and within that you have your Foundation training programme director. And then for each Foundation doctor, they will have an educational supervisor who oversees their training and progression throughout 1 year or both, and a clinical supervisor who supervises each Foundation doctor during a particular placement. The new curriculum emphasises the importance of holistic care, and Foundation doctors should be able to apply the principles of holistic care to each patient, looking at their physical, mental and social health. The Foundation programme also emphasises the acquisition of generic skills, and the programme itself provides a very broad experience with placements in a variety of areas of medicine, including community or primary care, acute and chronic hospital environments, mental health settings, and also environments that provide health promotion. So there is an official curriculum document which includes a lot of information, but including teaching theory, curriculum design and aspects of the curriculum quality. So therefore there will also be a rough guide to the Foundation programme which will contain everything you need to know about the curriculum and also the assessment process. Everything on these slides is also included in the rough guide with further clarifying information on some topics should you want to refer to a PDF or a paper copy. So the aims of the Foundation programme. The programme is part of the continuum of medical education and it's designed to support the transition from medical student to doctor, and this covers a crucial stage in medical training. It's the beginning of the doctor's working life as a healthcare professional and also postgraduate learning. It provides the opportunity for newly qualified doctors to deliver the care required to meet population healthcare needs, but in an environment that supports the doctor's development and protects patients. So successfully meeting the requirements of the F1 curriculum demonstrates that the Foundation doctor can work safely with less direct supervision and increased responsibility. 1 full year of training must be completed and the Foundation doctor is then eligible for full GMC registration and can progress to F2. Successfully meeting the requirements of the F2 curriculum demonstrates that the foundation doctor can work safely with indirect supervision in non-specialist medical environments and can lead care on a day-to-day basis, recognising and understanding context and variability of clinical presentations. So right at the end, the Foundation Programme Certificate of Completion, or the FPCC, can then be awarded, which is a requirement for specialty or GP application. So the curriculum expects that when a doctor completes foundation training, they should reach a level of practice at which they can be entrusted to deliver safe, compassionate care with indirect supervision and be able to enter general practice or specialty training. So what do we hope foundation doctors will learn over the 2-year programme and feel confident with at the end of the programme? The curriculum has 3 main outcomes, and these are called the higher level outcomes, or the HLOs. So to complete the programme successfully, the foundation doctor must demonstrate that they are HLO1, an accountable, capable and compassionate clinician, HLO2, a valuable member of the healthcare workforce, and HLO3, a professional responsible for their own practice and professional development. So these are the higher level outcomes, and they underline the generic nature of foundation training. The HLOs are further broken down into 13 professional capabilities, and these form the syllabus. So the first set of capabilities refer to patient care and how the foundation doctor is as a clinician and relating directly to patient care or indirectly. The second set relate to the foundation doctor integrating into the healthcare workforce in terms of working with others, teaching others, improving healthcare settings, and also self-care. And the third set refer to professional requirements and expectations. So these capabilities can be learned or demonstrated in the workplace during the programme, and at the end of each level of training, the foundation doctor must provide evidence that they have fulfilled or they can show each FPC. And a higher level of performance is required to demonstrate each capability during F2 compared to F1. So looking closer at each HLO, what each professional capability means, and thinking about what this might mean in practice. So number 1, clinical assessment. This is the ability to assess patients in needs in a variety of clinical settings, including acute, non-acute and community. 2, clinical prioritization. So can you recognise and, where appropriate, initiate urgent treatment of deterioration in physical or mental health. Number 3, holistic planning. So diagnosing and formulating treatment plans with appropriate supervision that include the ethical consideration of physical, psychological and social needs of the patient. Number 4, communication and care. Does the doctor provide clear explanations to patients or carers, agree a plan and deliver healthcare advice and treatment where appropriate? And lastly, continuity of care. Does the doctor contribute to safe, ongoing care, both in and out of hours? HLO2, so number 6 of the 13 capabilities, sharing the vision. The doctor works confidently within and, where appropriate, guides the multi-professional team to deliver a consistently high standard of patient care based on sound ethical principles. So number 7, fitness to practice, developing the skills necessary to manage their own personal well-being. Number 8, upholding values. Does the doctor act as a responsible employee, including speaking up when others do not act in accordance with the values of their healthcare team? Number 9, quality improvement. Do they take an active part in processes to improve quality of care? And number 10, teaching the teacher. Has the doctor taught and presented effectively? And HLO3 are more about professional requirements and expectations. So FPC 11 is surrounding ethics and law. Does the doctor demonstrate professional practice in line with the curriculum, GMC, and other statutory requirements through the development of a professional portfolio? Number 12, continuing professional development. So developing practice, including acquiring new knowledge and skills through experiential learning, accepting feedback, and if necessary, remediation, maybe reading, and if appropriate, through research. Number 13, understanding medicine, which is essentially understanding the breadth of medical practice and showing that the foundation doctor can plan a career. So when we say we hope you'll be able to achieve or demonstrate a certain capability, whether it's something clinical like in HLO1 or showing that you're an effective teacher in HLO2, what does this mean? What do you need to do to show that? Or rather, what sort of behaviour comes under that capability? So if we take FPC1, for example, clinical assessment, this table shows the behaviours that you might show in F1 and also shows kind of increased performance in the behaviours that you might show in F2 that shows you are sort of leading care and undertaking care in not necessarily quite direct supervision as in F1. And this table is a part of an appendix that will be in the rough guide, so you can refer to these behaviours whilst you're building your portfolio. So if we have a look, the F1 behaviours that show that you can assess patient needs in a variety of clinical settings, including acute, non-community and community, are things like, can the doctor communicate with patients sensitively and compassionately and assess their needs? Do you understand that presentation, including physical signs that might vary in patients of different backgrounds or different ages, or maybe between men and women? Use collateral history and alternative sources of information when appropriate. Can the doctor examine the physical and mental state of patients sensitively, maybe with a chaperone, eliciting and interpreting clinical signs, and including those from the mental state examination? And can you recognise vulnerable individuals, including maybe those at risk of abuse or exploitation, and demonstrate appropriate consideration of safeguarding issues? And then F2 behaviours. Is the doctor confident in patient interactions in lots of different settings? Can you appropriately instigate a range of standardised assessments more routinely? So asking for mental state exams, suicide risk scores, confusion assessments, pain scores, continence VTE, nutrition assessments, all sorts of things that can help you assess a patient that you might not readily think of as an F1. You actively seek symptoms and clinical signs that confirm or refute diagnostic possibilities, or demonstrate focused assessments in appropriate contexts and in a safe manner. And then taking a different example from HLO2, FPC 10, teaching the teacher, can the doctor teach and present effectively? So how you would demonstrate this, for example, as an F1, would be showing that you can provide clear explanations in a clinical setting, including educating patients about their conditions and their therapies. Or can you plan and deliver a formal teaching session using appropriate teaching methods? Whereas in F2, the sort of behaviours you might display are delivering teaching to students or less experienced doctors or other healthcare professionals or trainees, giving feedback to students or F1s or other workers on their own performance, and expanding your teaching repertoire by presenting or teaching in other settings or showing that you can use different teaching techniques. Now, these aren't necessarily behaviours that you need to do. You don't need to do every single one of them, but these tables provide you with ideas of what behaviours you can demonstrate. So going on to the approach. How do foundation doctors learn during the foundation programme? And there are three kind of approaches that we use in the curriculum. And the most important one is experiential learning. And this is where the doctor will have most of their learning experience. And it's the daily experience in the clinical environment with colleagues and with patients. Then a smaller amount of the learning will take place directly, which will be in the form of a formal and varied local teaching programme dedicated to foundation doctors only, and then self-development as well, which is self-directed learning from the foundation doctor. So the programme really requires the foundation doctor to take a proactive approach to learning. So they need to create opportunities to perform and reflect on those, and for trainers to observe and provide feedback as well. So discussing more about the experiential approach. Activities in each placement will kind of vary depending on the placement that you get. But the foundation programme makes sure that the doctors are exposed to environments that provide a significant range of experiences and therefore help the doctor to acquire the different curriculum outcomes. Most programmes are 3-4 month placements in each year. Other formats are permitted, such as fellowships or less than full time, but always clinical training should involve direct patient care and good educational support. So if we think about what kind of experience you might have, if you think about multidisciplinary team meetings, for example, on a stroke unit, working with the physios, working with the speech therapists, experienced nurses in a dialysis unit, ward rounds, clerking patients, assisting in theatre, maybe seeing patients in community clinics, maybe working with palliative care nurses on the ward or in your palliative placements, managing acute deteriorations on the ward or on the medical take, maybe being involved in chronic care, assessing mental health patients, cardiac arrests. The list is massive. There's so much to learn from experiential learning, and obviously that's the best part, and that's part of being a doctor. So that's the experiential approach, and those are all of the things, for example, that you might be involved with on a day-to-day basis during your foundation programme. So in each placement, the foundation doctor will have a clinical supervisor who is responsible for the foundation doctor's training within a specific placement. And also they will be supported by other professionals who are working in the environment with them. So pharmacists, nurses, other doctors, physios, professionals such as those. And a few of these will be selected by the clinical supervisor, and they will form the placement supervision group, who will give kind of regular and more formal feedback to the foundation doctor. And this is so important because then it means the foundation doctor can develop their skills under supervision. And it means that they can reflect on their progress and receive feedback from these professionals in their placement. So the clinical supervisor should at the beginning orientate the foundation doctor to their new placement and hopefully offer feedback midway through to highlight areas of good practice and guide their development, and also complete at the end of placement report. So what are the other methods of learning that I mentioned? The reason we have these is not all the foundation programme curricula can be learned or practiced in the clinical setting, and it's important to complement that experiential learning with a formal teaching programme and also self-development. So the new curriculum places, particular emphasis on certain topics that we know are important to include in the teaching programme. So the direct learning in the programme is specific to foundation doctors, and the topics are mental health, including mental illness, health promotion and public health, simulation, leadership, understanding quality improvement methodology, also how you appraise evidence, importantly careers guidance, integrating acute illness into chronic disease management and multiple comorbidities, frailty, end-of-life care, high-risk prescribing, teaching skills, patient safety, safeguarding, and use of new technologies and the digital agenda. So local educational providers or foundation schools as a region will compose their own teaching programmes. But importantly, they should be including all of these topics. And the formats might include lectures, might be practical sessions, small group work, or specified e-learning and potentially simulational as well. So other professional activities that are in the clinical environment, but important to learning opportunities too, include things like teaching sessions in your department, morbidity and mortality meetings or peer review meetings, journal clubs, grand rounds and Schwartz rounds, Barlint groups, or multi-professional meetings. And all of these things are called non-core learning. So they're not core learning, which is your kind of direct learning teaching program and all the topics that we just discussed. It's more learning that is not directly kind of clinical in the clinical space, but is non-core learning kind of in the experiential environment. Also, of course, foundation doctors will want to develop their practice in their own way and kind of enhance knowledge or explore areas of interest. And it will be largely self-directed, but it might be instigated at the suggestion of an educator or as a result of feedback. And this could include online learning, reading, making a reflection, doing non-core learning, maybe departmental teaching, for example, and all foundation doctors should now be given time for this self-development. So how are you supported to follow the curriculum and develop as a clinician and meet the higher learning outcomes? So across each training year, the foundation doctor will be assigned an educational supervisor, and this person will help guide the foundation doctor's personal and professional development and monitor their progress against the higher learning outcomes and the FPCs. So the ES and the foundation doctor need to meet regularly to discuss progress. And at the end of each placement, the educational supervisor should meet the foundation doctor and complete the end of placement report. And that will indicate whether the foundation doctor is on track to demonstrate all the professional capabilities at the level required for that training year. And that their trajectory will mean that they will pass the end of the year. The educational supervisor is also a source of pastoral support and also a point of contact for raising concerns about something in the clinical environment. So moving on to assessment. So keeping a good record of your professional development activities, reflections and feedback from others is required of doctors at all levels for medical appraisal, which demonstrates fitness for practice. And it's no different for the foundation doctors. Actively cataloguing achievements and progress allows foundation doctors to celebrate their strengths and also identify areas for development. So the foundation doctors will keep a record of clinical and professional behaviours that they have demonstrated in the workplace, and they do this via feedback from colleagues and their supervisors, and they kind of collect this evidence and maintain that record in an online portfolio, which is the foundation e-portfolio. And the evidence recorded will be a combination of experiential learning, direct training and self-development, and should ultimately demonstrate that they are proficient in all the foundation professional capabilities. So Horus is the foundation e-portfolio website that's used in England, and Turris is used in Scotland, Wales and Northern Ireland. It's important that the e-portfolio is kept up to date by the foundation doctor as they progress through the year, and evidence should be recorded in the portfolio from all placements undertaken. And this shows that the doctor is learning and engaging with each placement and can show that they are able to practice in a variety of settings. The e-portfolio is submitted at the end of the year, at the end of each year in training, for review and decision on progression to the next training stage. and this process is called ARCP. So in summary, evidence recorded in the portfolio will be from a combination of experiential learning, direct training and self-development, though most should be through experiential learning and therefore provide evidence of capability in the workplace, which is the most important and where doctors will be spending the majority of their time. And this evidence will hopefully fulfil all three HLOs. So if we look at the types of assessment, we have formative and summative assessment. So your formative assessments that you will mostly do in each placement include supervised learning events, placement supervision group, multi-source feedback, which is the TAB, team assessment of behaviour, your personal learning log, the summary narrative and curriculum linkage of your portfolio evidence. And summative assessments include your supervisor reports, clinical and educational, and also the prescribing safety assessment in F1. So while working in the clinical setting, obviously the doctor will undertake various tasks and receive feedback. And hopefully some of this feedback will be recorded formally as SLEs. The 2021 curriculum doesn't specify a particular number or particular types of SLEs to be included, but offers them as a way of recording the progress and showing that you are proficient in the 13 FPCs. So mini-KEX, DOPS and CBDs, which I will explain on this slide in a moment, but just going back to the other slide before. So mini-KEXs, DOPS and CBDs will be used to record activity for HLO1. Leader and developing the clinical teacher are more likely to be used for HLO2, and learn can be used in any area. So if we look briefly now about what each of these mean. So the SLEs are supervised learning events, which you may or may not, or the foundation doctors may or may not have come across at medical school. So a mini-KEX is a mini clinical encounter. So it's direct observation of the foundation doctor undertaking an interaction while at work, which might be on the ward. A DOPS is a direct observation of procedure. So as someone who is giving the feedback directly observing the foundation doctor doing the procedure, but also ideally including observation of explanation to the patient of why the procedure is being performed, the process of consent, including understanding complications, as well as feedback on the technical capability of the procedure itself. CBD is a case-based discussion, so this can be away from a patient. It's not a direct observation, more of a discussion of a case after an unobserved encounter in the workplace environment. So LEARN is a learning encounter and reflection note. It's a form for recording like the SLEs above and other forms of evidence such as performance and simulation. So essentially, if you're unsure which SLE to record a form of feedback or performance in, you can use the LEARN form. The leader form is for recording feedback following event where the foundation doctor has shown leadership skills. And finally, DCT, or developing the clinical teacher, is a form used for feedback on a formal teaching session or a presentation that the foundation doctor has delivered. So the placement supervision group that I discussed earlier is a couple of healthcare professionals that are nominated by the clinical supervisor in a particular placement. And the reason that this is done is then individuals will be identified who can feed back to the foundation doctor on a day-to-day basis. And these people or professionals may also contribute to the TAB, which I will explain in a moment, and also feed back to the clinical supervisor on the foundation doctor's performance for the end of placement clinical supervisor report. Now, for at least one clinical supervisor report each year, they have to include a report from the PSG. So at least in one placement a year, there has to be a proper PSG, and this has to be at least 3 members in it. It's used mainly to inform HLO1, but some evidence for HLO2 and 3. So talking about the multi-source feedback and the tab, it's essentially a form where professionals that work with you will provide feedback on your attitudes, on the foundation doctor's attitudes, behaviours and professional skills. So this is used to obtain feedback mostly for HLO2, the healthcare worker, and kind of integration into the healthcare team and how you perform in a team environment and with your other colleagues. And you're expected to carry out this at least once in F1 and once again in F2. And it's used formatively to develop professional behaviours and receive feedback on those professional behaviours. But essentially, a satisfactory tab is a requirement to complete each year. So although it's a formative assessment, it does need to be completed and satisfactory to complete the year. Okay, the personal learning log is essentially a record of the foundation doctor's core and non-core learning. So in terms of core learning, which is your direct training and the training programme delivered by the educational provider, the foundation doctor is required to log a minimum of 30 hours of this type of learning. And then non-core learning, which is essentially any learning in the experiential environment, for example, the list mentioned earlier, like departmental teaching or Barlint groups, or self-development, there needs to be 30 hours of that also logged, and they should be relevant to the foundation programme capabilities and recorded in the portfolio as non-core learning. So a note on reflection. Like all doctors, foundation doctors are required to reflect on their practice. And the main form of reflection required by foundation doctors is called the summary narrative. The summary narrative is a written reflection by the foundation doctor, cataloguing their journey through the programme and reflecting on their progress against the HLOs. This is important because it will facilitate self-development and help the foundation doctor identify areas of the curriculum where they might not be as strong and maybe need some more feedback and more work on from other colleagues. So other recorded reflections can also be done, and they can take the form of a personal reflection or reflection with a supervisor or a group reflection. And these may be based on maybe individual cases or events or on overall development and progress. So the summary narrative, there's 3 of them, and they will be written against each LO to show the rationale for the evidence that has been collected and mapped to the foundation programme capabilities. There's no minimum number of SLEs, and the foundation doctor needs to link adequate evidence to the 13 FPCs in accordance with the hierarchy of evidence, which is on the right there. So most of your evidence should be experiential learning, so it should be lots of SLEs from supervisors and colleagues from your placements, but then also obviously evidence in your portfolio will include your learning log and the core learning and non-core learning that you've done, as well as maybe other reflections, feedback from colleagues on tabs and feedback and things. So you will have lots of evidence in the portfolio, and it will allow up to 10 pieces of evidence per FPC, and each piece of evidence can be used 3 times. So although there's no minimum number, we encourage foundation doctors to link adequate evidence. So the clinical supervisor reports will be filled out for each placement, and the clinical supervisor should consider the foundation doctor's performance in the clinical environment and gather lots of information. And the information used to inform this report will be information such as SLEs, feedback from the PSG, reflections, any learning that you've done, and this will all be regarded as formative learning. But the supervisor report that is produced is a summative assessment that will be used to inform the ARCP panel when it convenes. The educational supervisor as well will fill reports at the end of each placement, but at the end of the year, the educational supervisor makes an end of year report. And in a similar fashion, this will provide a summative assessment to the ARCP panel, giving an idea of whether this doctor should progress to the next stage or not. So the report will provide an assessment of all of the following things. So has the foundation doctor linked enough evidence to each FPC to show that they have covered the curriculum? Is there evidence of learning, both core and non-core? Have they got satisfactory clinical supervisor reports? Have they completed the 3 summary narratives detailing their rationale for the evidence against each HLO? Is the TAB and PSG satisfactory, and have they got any evidence from any other meetings? And the other specifics for assessment are, particularly for F1, the prescribing safety assessment. And this is important. It demonstrates the foundation doctor's competency in relation to the safe and effective use of medicines. So to complete F1, the foundation doctor must have passed the PSA within the 2 years prior to entry into the programme, or hold a valid pass certificate when they complete F1. So if we just look at the overview, we have the 3 HLOs as discussed at the beginning, and the breakdown of each HLO into the foundation professional capabilities. And then underneath you have the assessments that will help inform each FPC and show whether you have demonstrated what that FPC is. So for example, for HLO1, you'll have those things at the bottom that will go towards showing that you are capable and you are an accountable, capable and compassionate doctor. And that there is your 2 reports, your TAB, your PSG, evidence from your e-portfolio, and potentially your PSA certificate as well, which shows that you are competent and can safely use medicines effectively. So ARCP, at the end of each year, the portfolio and everything that we've discussed is submitted to the annual review of competency progression panel, and that decides if the foundation doctor has achieved the curriculum requirements and will progress to the next level of training. The panel will make their decision based on feedback and evidence selected by the FD in their portfolio. And as we've explained, there's no fixed number of pieces of evidence required, but you just need to provide sufficient evidence to demonstrate you are proficient in each capability. And this is just a slide basically summarising everything needed for ARCP, and it will come in sort of form of a checklist, so that when the foundation doctor comes to ARCP time, which is usually in May or June, the doctor and the supervisors can look against these requirements and check that the foundation doctor has fulfilled all the requirements or filled out the necessary forms. So once the ARCP panel convenes and decides an outcome which represents progression, the foundation doctor can move on to the next stage of training, or indeed complete the programme. So in summary, the 2021 foundation curriculum was written to link explicitly with the GMC's generic professional capabilities, and it includes a clear statement of the expectation of equitable treatment for all foundation doctors. We have higher level outcomes, which were previously called sections, reduced from 4 to 3, and the foundation professional capabilities have been reduced from 20 to 13. There's also no specific number of SLEs that need to be undertaken, but examples of practice must be submitted as summative evidence against the learning outcomes and across a variety of placements. The importance of the placement supervision group has been emphasised and also made mandatory to make sure a broader range of professionals provide feedback, and the curriculum introduces a more formal hierarchy of evidence to emphasise the importance of direct observation in the workplace as the most crucial evidence that the foundation doctor has fulfilled the HLOs. Additionally, specific core teaching sessions make explicit the need for training programmes to provide teaching in certain areas, including simulation, and it endorses current practice for the recording of a personal learning log of core and non-core learning. It defines the role of a doctor, it makes a specific statement regarding the importance of mental health and specifies a syllabus covering this. The summary narrative provides additional opportunities to reflect on progression and curriculum achievement, and the review has provided an opportunity to develop a curriculum that considers and incorporates recent work in the area of differential attainment and highlights the importance of monitoring this, and it allows for reasonable adjustments to the assessment of performance. So thank you so much for listening, and I hope that has given you a much better and clearer understanding of the new foundation programme curriculum. Please refer to the documents, especially the rough guide to the foundation programme curriculum, which will have everything that we have just discussed and more. Thank you.